Okay, well, why don't we start where we left off yesterday? Excuse me. Thomas, why don't you take this case? Now, remember, we're talking about congenital developmental abnormalities in the lumbar spine. So, Thomas, what do you think of this case?
Right, so asymmetry of the facets, and yeah, there may be a transitional vertebral body at this level.
So we can see this looks kind of odd, and the spinous process doesn't really look symmetric in the midline. And then if we look, we see a lot of asymmetry in the foramina. If we go to the sagittal images, it looks like this.
Yeah, it's sort of a wedge-shaped vertebral body.
Well, so we're at the edges. So we're looking at this area here, and we see two nerve roots. We see a disc here, but we're missing a pedicle. So this is actually a congenital absence of the pedicle. And if you go back, all this asymmetry back here is actually due to the anomaly. And you'll occasionally see this, and you just have a lack of a pedicle, and therefore two nerve roots really coming out of a very enlarged foramen. So, Sahar?
Okay, we have two coronal views of the lumbar spine, and it seems that we have sacralization of the left L5 transverse process.
So, and here it's only on one side. So when you see it only on one side, like this one, you've got to count and make sure how many lumbar vertebral bodies you have, because it can be anywhere from 4 to 6 lumbar vertebral bodies. And then obviously you're going to put increased stresses on the level above this. Usually this is going to be L5, but it doesn't have to be. And then you're going to have increased risk of degenerative disease at the level above it, because you have abnormal forces here with fusion on one side but not on the other, which produces a lot of strain above it. So, and what's this disease called? Or what's one name for this? People's names?
I'm not sure.
We talked about it last time.
I wasn't here. I think I was in the last lecture. Yeah. Okay.
Anybody else? What's the name of this syndrome?
Bertolotti's.
Yeah, Bertolotti's syndrome. So, you weren't here. So that's very important to remember, because, as I said last time, I think it's one of the most commonly missed significant diagnoses in imaging of the lumbar spine.
Sorry. Okay, assuming we're not kind of oblique, well, I think we are a little bit oblique, but still it looks like there's this bony abnormality, maybe a missing pedicle on the left. I don't really know from this alone.
Okay, nice to have you. Here's a coronal view.
Yeah, it's like a butterfly vertebral body. I think that's what this is called.
A butterfly body is also called a sagittal cleft. And again, a developmental where you don't have fusion of the growth areas on the right and left side of the vertebral body. Okay. Shiv, what do you think of this one?
Okay, it looks like the sacrum, that's one level vertebral body. It looks abnormal to me. Yeah, it looks like possibly a butterfly.
So this is the same thing here, where we have a sagittal cleft in the middle. In this case, it's S1. It's more commonly seen in the lumbar area. Okay. Let's see now. Thomas, what do you think of this one?
So, also a cleft in the central part of the vertebral body.
Right. So this was at the L5 level. Here's it on the axial plane. There it is on the sagittal, right through the middle of it. So again, it's a sagittal cleft or a butterfly vertebral body. Different ways these can look. Right.
Okay, so it seems another. It's incomplete sagittal vertebrae. I think sagittal. Yeah.
So here we see what looks like a little bow tie.
Yeah.
And then this could just be schwung nodes or an old compression fracture, but on the axial images, we actually see that there's a cleft here. What else do you see here that would be very important if somebody was thinking about surgery?
What else?
So the other thing we
the
see
cord.
here
Okay, there's some
is we've got separation.
two cords.
Actually, if you look here, you'd have to see it on other images. The conus is low lying. At this level, we actually have diastemalia. And this usually has either a fibrous or a bony bridge between the two. And the important thing is that at surgery, if you go yanking around, you can cause neurologic damage if you don't know that the cord is abnormally fixed due to diastemalia.
Okay.
What level is that, John?
I think this is L1.
I thought so. So also 1, 2, 3, 4, 5. Yeah. Okay.
The cord is the conus is inferiorly placed.
There's the conus is what tethered to the
I think the conus.
posterior elements.
Yep.
Right. Yeah. This is not a very good condition.
Right.
To have.
Something in the canal. I wonder if that's artifact around it. If that's, I don't think it's metal. Oh, okay. So it's bone. So it's diastometamyelia, right? With
This has a bone bridge rather than a fibrous bridge between the two. Let's see, Shiv, what do you think of this case?
A 34-year-old man complains of both lower leg weakness. So we have a plain film. It looks like there could be some squaring of the vertebral bodies, maybe. They look sort of weird in morphology, I guess. The pelvis looks okay. Okay, so this one looks like there's short pedicle length and there's scalloping of the posterior vertebral bodies, which you can see in achondroplasia.
Good. Achondroplasia. Okay. Thomas, John, do you want to comment on that?
Well, it said a lower leg. I call that the leg. That would be below the knee. The lower extremity is a different story. Now, lower leg is weakness. I'm not sure I quite understand what that means, but I suppose that's below the knee.
You have to speak Korean.
It's the language is that's one of the problems we have in medicine. The way we call things. Lower leg, I suppose, means below the knee.
Yeah, I think they mean the leg here, not the lower extremity. But it's probably just. Actually, my guess is they just mean lower extremity, just lower extremity weakness is probably.
Yeah, it's kind of confusing.
Yeah, I agree. And it's like achondroplasia. Very nice, good. Okay, Thomas.
So, sagittal and axial view, and I guess the cord's lower than.
Yeah, so it's a low-lying conus or a tethered cord here. The conus was actually down around here, down around the L3 level here. Okay.
Okay, back pain. And we have some degenerative changes of the left facet. It seems that there's a cyst in the left facet, and the cord, I don't know, there's some bulging of some herniation of the cord, or that's just the cut that we are getting?
This is just the CSF here and the nerve roots on either side. So what do you think that is?
It looks like a cyst, a left facet cyst, synovial
cyst. It's right
cyst.
on T1, and it's right on T2.
Oh, it's maybe lipoma, actually.
There we go, and then here are the sagittal images.
So on the sagittal, is it that L? It's hard to find it. Okay. Probably
they're pain. Those are painful.
Yeah, facet lipoma.
This is a facet lipoma. So it's a. I'm not sure if these lipomas are painful. They're pretty rare.
I was thinking. I'm sorry. I thought this was a cyst.
Yeah. No, this is actually fat in there, and there's a little lipoma within the facet joint.
Well, you see, I'm the orthopod, and I don't know all those things like lipomas and.
Right. That's right. Yeah, I was just putting this out to the fellows that it's easy to call this a cyst, but then when you look at it, it's bright on T1. So it's not just fluid. I guess it could be hemorrhagic, but that's kind of unlikely. We don't see any trauma here. And then when you look through this, it's nice and smooth here. And this is a lipoma of the facet joint.
Yeah, I got it. I boo-booed.
Okay. Sam?
Okay, there's a lot of
lipomas don't hurt.
There's a lot of end plate disease, and I think prominent epidural fat, at least posteriorly, as far as the cord.
It's epidermal lipomatous. And this is one where a lot of people have a lot of arguments. I think many people believe that this can actually produce a central stenosis, and we can see that the nerve roots are certainly not normal in their course here. But not everybody believes that the actual lipid tissue here is actually doing the compression, that it may be just an innocent bystander. So I think that's debatable. But there are people who believe that epidural lipomatosis can be a symptomatic condition. As opposed to this, Shiv, what do you think of this?
Okay, it looks like there's a mass in the spinal canal, and it looks like it's T1 hyperintense and T2. It looks like it Fatsets on the T2 Fatsat or the stir. So it looks like a lipoma.
Yeah, so this is really an epidural lipoma, which in this case really is markedly compressing the neural canal. Right. And going further here, Thomas, what do you think of this case?
So this is another lipoma epidural.
Well, let's see. I don't see the posterior elements here. There's a huge thecal sac here, kind of the opposite of what we saw before. And then we have a lot of fat around it, fold in the fat posteriorly. And this is a Chiari II malformation. And if you go, and here we can see that the tonsils are kind of herniating down into the cervical canal in this particular patient. Okay.
Okay, this can have two coronal, T1 and T2. And is it T1 fat set or? Okay.
So this is a younger individual. And this just shows what some people call dural
Okay.
And that can be seen in neurofibromatosis. And this patient had neurofibromatosis 1.
Okay.
That was a duralactasia that you can see.
Can you describe the finding, please?
It's the prominent indentation here, posterior to the vertebra, and this is not something that I call on an interpretation, because it also looks like you may have some thickening of the annulus here at each of these levels. But this is called duralactasia. And so we saw it in some other cases where you see big expansions of the dura in other areas. But this kind of scalloping of the posterior aspect of the vertebral bodies is something that you can see in neurofibromatosis. So you look for neurofibroma.
So that's actually thickening of the dura there?
It's the dura extending. In this particular case, it doesn't look like it.
That's a very wide canal, isn't it?
It's a very wide canal, and this is fat in through here. So I don't know. Let's skip this case. That doesn't make any sense. But I think this is in this. I think no, this is a different patient. Not. Yeah. Let me see something. Yeah, I don't believe that. I think that's just wrong. So, who had that case?
I did.
You did. Take this case instead.
Okay. So we have, looks like very large nerve roots or fluid around the nerve roots, exiting nerve roots, yeah.
Okay.
And it's extending beyond the neural foramen, so I'm thinking of like, yeah, some nerve tissue tumor, like multiple. Yeah, it's going, yeah. Looks like a nerve tumor, like schwannoma.
What is this?
Is it like neurofibromatosis, like plexiform? It's not really plexiform. Okay.
These are neurofibroma.
Okay.
Neurofibromatosis, right? And typically they'll have enlarged foramina because it's something that's been there a long time, so the bone is remodeled around it. Okay. Patient came in with back pain.
Looks like at least one focus of, I don't know if that's a nerve root superiorly. Yeah. Thicken and with increased signal.
So what would you want to look at?
Well, I'm wondering if that's fluid or just nerve.
Axial, right?
Well, axial would be nice, sure. Okay. This is a PDFS, or is it enhanced T1? No, it's got to be a PDF. It's got to be enhanced T1 because there's no CSF. So it's probably, I imagine this is enhancing. So it looks like a nerve sheath tumor. Could be, I don't think NF if it's just the one, but it could be like a schwannoma. Or is there more? More peripherally, there's more. It could be NF, could be neurofibromatosis. Neurofibroma, sure.
Okay.
Hello, Dr. Cruz. This is Pablo.
Hi, Pablo. What do you think of this next case?
Let's see. Chronic back pain, radiating pain. Let's see. We have a sagittal. Looks like it's a T1. So I'm wondering if that's just a plane it's a little bit off S1 from S2.
What, down here?
Down, yeah, right there, but that's at the edge. It's probably just the plane is very lateral to the neuroforamina. Okay, here's a T2, and looks like the nerve roots are thickened. Wonder if it could be arachnoiditis. Well, the sac is full of nerve roots in this axial view, and normally they should be in the dependent portion of the sac.
Yeah, but if you...
there's sorry. Yeah, no, I just saw on the left neuroforamina, looks like there's a soft tissue lesion there. Maybe it's a schwannoma right there. Yeah.
You think these are all schwannoma?
Pardon?
Do you think all of these are schwannoma in the thickosac?
No. The nerve roots, the thickening, I would think arachnoiditis, if it's thickened.
But arachnoiditis causes clumping of the nerve roots. It doesn't cause
Clumping.
thickening of
That's true. Yeah. It's chronic pain. Let's see
So
here.
a little farther down.
I don't know if neurofibromatosis could do that. I know that you could have a neurofibromas normally, but I don't know if it could cause diffuse thickening.
There's several diseases that can do this, but by far the most common one, which we usually see once you hear, yeah, there you go,
Charcot-Marie-Tooth, yeah, Charcot-Marie-Tooth, okay.
And it can cause peripheral neuropathies associated with it, and you get diffusely thickened nerve roots, but it can be a little bit focal. And here you can actually see that there are nerves out here that are all thickened as well.
Oh yeah, and the sagittal you show me first, those nerve roots are thickened.
Yeah, these are thickened. That's too big of nerve root. Yes, John?
It's a progressive disease, Charcot-Marie-Tooth, from the feet up, and I think at least paralysis and death at an early age.
Yeah, it's not a good disease.
No, my chief's sons, they were twins. They both had it.
Oh.
It was kind of an interesting situation, and his specialty was feet. In fact, he casted every baby that had flat feet, which means 85 kids born in that hospital pretty much had their feet casted every Saturday, which was really nutty.
Yeah.
But that's the way it was. He was the chief.
Wow, that's incredible.
Incredible is right. I got pretty good at casting.
Okay. Shiv, what do you think of this one?
57-year-old man with chronic right knee and low back pain. So this looks like bone infarcts of the medial.
Don't really see a double line sign. I don't really see a Serpentius double line sign, but certainly we have loss of the normal fat signal, a lot of inhomogeneous signal on the PD fat side. Here, an axial image through the spine.
I guess the nerve roots don't look too thick. Yeah, normal cata. Okay.
But if we keep going farther down, we see this.
Okay, so it looks like masses associated with the exiting spinal nerve roots.
Well, these are all thickened nerve roots, but they're thickening. Okay. They're thickened outside. These are probably a little bit thickened too, but that's very thick. That's pretty thick. Here.
So maybe another Charcot-Marie-Tooth situation.
All these out here are very thick.
Super thick, yeah.
Inside, higher up, they were pretty normal. Look at the sacral roots here, markedly thick. And this was Charcot-Marie-Tooth with a neuropathic knee due to the neurologic disease. But in this case, higher up in the canal, the nerve roots looked normal. It wasn't, it got more peripheral. And as John was saying, this really often peripherally for two reasons. One is those are much longer nerve roots. So if you have an abnormal nerve, you're going to pick up pathology earlier, the longer the nerve is. And then sometimes the thickening kind of starts out more prominently peripherally and extends proximally. Okay, Thomas.
8-year-old female with gait disturbance at age 1, crow's feet with walking. So it looks like the nerve roots are also thickened.
Yeah. Look very thickened, and they're filling up the neural canal.
Right. And yeah, they're thickened there.
So things to think about are chronic demyelinating inflammatory polyneuropathy. I don't think I've ever seen any cases of that. Hereditary motor and sensory neuropathy. though just very familiar, NF1 and peripheral dural lymphomatosis. Lymphomatosis. And this is someone who has known lymphoma usually, and then Charcot-Marie-Tooth. So here's the feet.
I guess there's some pes planus and
So this, so if we go back here, this patient has, these are kind of enlargement of the nerve roots here in the collaquina, and we can see kind of some flat feet, and this patient has a sensory abnormality, and this was a congenital Charcot-Marie-Tooth syndrome 1A, and now that they actually can find locations on the genes where you have an abnormality which leads to this. So this is another case of Charcot-Marie-Tooth disease. And I don't know how many now, but I think that there are more than 7 different types that have specific genetic abnormalities associated with them. So most affect the myelin sheath, but some affect the axon itself. Usually start in late childhood, early adulthood, and pes cavus, like we saw in that last case, is quite common. And then very abnormal looking nerves on a histologic study. Here's another differential of different things that can produce thickened nerves, but the diffuse kind that we're seeing here is generally Charcot-Marie-Tooth, which in and of itself is actually multiple genetic diseases. Okay. See, you're done?
I think so. Okay, 30-year-old male with back pain. I see multiple, kind of like, or ill-defined, sclerotic lesions of the vertebrae. It's all over the place, yeah. And okay, it's dark on T1. Do we have T2? Okay, is it that one, the posterior thing? Okay. Okay, and then the kidney. Looks like there are like fat-containing lesions in the kidney. It can be like AML in the kidney, and okay, we have calcification in the basal ganglia bilaterally. Okay, it's, oh, I forgot the name. It's not the storage Weber, it's the other one. Tuberous sclerosis, yeah.
Okay.
I think that's misspelled.
Yeah, I think you're right.
It's tuberous. Thank you.
Thank you.
I just went to lift up Margie from the floor.
Oh, no.
Yeah.
Okay.
She has an attendant with her, and she just went down. Anyway, I'm sorry to interrupt you.
Okay.
Okay. So there's a lot of sclerosis in the posterior elements and the pedicles bilaterally. The rest of it, body, I don't know if that's just, is it thickened trabecularly or also possibly focal.
So we've got a lot of sclerotic changes, thickened trabecular.
This looks like Paget's to me. Oh, so it's multiple bones involved. I would still call this Paget's though.
Are the bones enlarged? They don't have to be, but often with Paget's they're enlarged.
No, I don't think they're really too enlarged here, but the thickened Osteopathia Striata.
So this is Osteopathia Striata, which you get the thickened trabecular bones and kind of a striated appearance like this, but the size and everything else is pretty similar. And histologically, these look like bone islands.
You see that in other bones as well.
Yeah.
I think.
Yes, you do. Okay, Pablo.
Let's see. We have a frontal lateral view of the lumbosacral spine, and there is sclerosis of the end plates of all the levels. Let's see the pedicles, and here we have a bone scan. Looks like there's some uptake of the vertebral bodies, maybe the SI joints, and let's see. So skull X-ray. Sure, I see any. Okay, osteomesopyknosis.
So they get back pain and destructive passive sclerosis of vertebral end plates like we're seeing here. Normal height.
Was there something abnormal in the skull X-rays or
just some inhomogeneous. What?
inhomogeneous?
Isn't the skull thickened?
Yeah, the skull might be a little bit thickened, but that could be and then you got a little inhomogeneity, but nothing very specific here. And the same with you can see kind of a coarse and thickened pattern of the bones here. So not real common. I think Paget's disease when you think of myelofibrosis, osteomalacia. Okay, great. Hey, well that's the end of the lumbar spine. So why don't we stop here today, and we'll take up another topic tomorrow. Maybe we'll start the cervical spine too.
I appreciate that, John.
Good.
I think I might have to take Marsh to the hospital
Tomorrow?
By ambulance.
Right now?
So,
okay.
Yeah.
I'm sorry, John. Let me know how it goes, okay?
We'll do.